Hello everyone. So today I'm going to discuss enuresis, and this is the second video in our pediatric for PLEB 2 series. The term enuresis is more commonly known as bedwetting, and this term is more often used when a child is more than 5 years of age, because up until the age of 5 years, full bladder control is not achieved. Okay, now enuresis can be of two types: primary enuresis or secondary enuresis. Primary enuresis is the term which is used when the child has not been able to remain dry, and he has been wetting bed continuously since birth. Okay, and secondary enuresis is the term which is used when the child has been able to remain dry for 6 months, at least for a duration of 6 months, and now he has start wetting his bed again. Okay, so that is secondary enuresis. All right, now we have different causes and differentials for enuresis, and we will discuss all of them in detail. Also, I will discuss how to take a history and how to provide management and what are the different IPS points for when you are dealing with an enuresis case. Okay, so the first differential that we have for enuresis is urinary tract infection, and as you all know, that in UTI we have polyuria. Okay, so the children who are having urinary tract infection will be wetting their bed. Constipation is another very important differential to keep in mind, because if the child is having constipation, there is buildup of poo in the rectum and it is pressing upon the bladder. So the volume of the bladder become smaller than normal and is not able to hold more amount of urine, and consequently the child wets his bed at night. Now, diabetes mellitus also presents with polyuria and polydipsia, and in kids it can present with bedwetting. Okay, stress and anxiety. Stress and anxiety is also a big factor to watch out for, especially in kids. Non-accidental injury or maltreatment or bullying at home or at school or at nursery can present with bedwetting. Okay, so keep an eye out for any stress and anxiety that the child might be experiencing. It can be because of any changes in the home, for example, separation of parents or birth of a new sibling or change in school, etc. Lifestyle. A huge factor that contributes to bedwetting in kids and is more common is lifestyle issues. So a child can be drinking too much fluid, especially before going to bed. Okay, or caffeinated or fizzy drinks. Drinking too much caffeinated or fizzy drinks causes the child to pee more and consequently result in bedwetting. And also irregular toilet routine. So if the child is focusing too much on something like watching cartoon or playing, he might not go to the toilet, and it can result in bedwetting. It can result in daytime accidents also. Okay, now let's discuss the data gathering for a case of enuresis. So you'll start with open-ended question. You will ask the parent to tell you more about it. When did it start? Was it dry before? Okay, this question is to separate primary enuresis from secondary enuresis. Okay, so was he dry before? And now this next question will be about the frequency, to establish the frequency of enuresis. So how many times per week? Is it every night? Is it every other night, etc.? And any daytime accidents as well. Okay. So any daytime wetting. Apart from that, we'll ask anything else to know about the cause of enuresis. So any pain on urination to rule out UTI. How are his bowel habits? Any weight loss, and is he more thirsty than usual? These questions are for ruling out diabetes mellitus. Now, lifestyle questions: does he drink caffeinated or fizzy drinks? Does he go to toilet before bed? And how much fluid does he drink at night? Any changes in the home or school recently? Okay. So, and any signs of stress or anxiety that are shown by the child, any change in behavior? These are questions that you must ask. Another important question will be that I forgot to mention here, but it's really, really important. You must ask the parent, how is your response, or how is the family's response to enuresis? Because if the family response is negative towards it, and they've been getting angry or scolding the child for wetting the bed, then this is going to cause even further issues. So you must ask the parent, how are you coping with it? How was your response to the bed wetting? Okay. And then we'll ask past medical history. So has he been diagnosed with any medical condition at all? Does he have any other sibling, any problem of bedwetting in the siblings previously? Okay, because siblings, the family history of bedwetting in siblings and also in parents is important because this can run in family also. If a parent has been wetting his bed in childhood for more than 5 6 years of age, then it's more likely that the child will also do the same. Okay, then we'll ask about any medication that the child might be on, any allergies, and any family history. Then we ask the birth questions, that is birth, the birth history, immunization history. So birth history is basically how was his birth? The child is small, so how was his birth? And immunization history, any is he up to date with his jabs, any recent jabs, red book, so are you happy with the red book? And developmental history, and so developmental history is not really needed here, and then diet as well. So we have already asked about the fluids, the fluid intake of the child. So if you are short on time, then you can skip the diet history as well. Psychosocial. So psychosocial, as we already asked about psychosocial in the differential diagnosis part, we were asked any changes at home or school recently. How was your response to the to the bedwetting? But if you are suspecting any maltreatment of the child, then you need to go into detail of the psychosocial history, who takes care of the child, who is at home, any social worker involved, any complaints from the school, etc. So then you need to go into detail of the psychosocial history. Ideas, concerns, and expectations. So ideas, concerns, and expectations, they are important in our station. Like keep in mind that your history has two part. One part is for the medical history, and the second part is for asking ideas, concerns, and expectation. If you skip asking for ideas, concerns, and expectation, no matter how good your medical history is, you will get only 2 marks out of 4 in the data gathering. And similarly, your management has two part. One part is for medical management, and one part is for addressing concerns and expectations. So if you provide very good and excellent medical management, but you forget to address the concerns, then the maximum score that you are going to get in the management part is again 2. Okay, so keep in mind asking about both medical history and ideas, concerns, and expectation and data gathering, and same in the management. Okay, so examination. In examination, we will examine the vitals of the child. We will measure the height and weight, and also abdominal examination, because abdominal palpation to look for any fecal masses. Okay, so it will depend upon your history. If you are suspecting constipation, then do abdominal examination. How we are going to manage this child? So first of all, we will explain the condition to the parent. Okay, that it's a very common condition and it is self-limiting, and we don't usually expect kids to achieve full bladder control before the age of 5 years. Different children achieve bladder control at different ages. Okay, so we need to really educate and reassure the parent regarding that. Okay, uh, in investigations, we need to do blood glucose and urinalysis to rule out UTI and diabetes mellitus. If you are suspecting any anatomical changes, however, then you also need to do abdominal ultrasound. Okay, bladder scan. Um, the first thing that we are going to try in Eurysis is simple behavioral strategies. Okay, so we will ask the parent to not to restrict the fluids, but allow the child to drink adequately during the day, but less at night time, and completely avoid fizzy drinks and caffeine. Make sure their child go to the toilet before bed, and sometimes keeping a potty near the bed, easy access to the child to the toilet at night is going to help the child as well. Introduce a reward system, like giving a star sticker or something, or candy to the child if he follow the behavioral medication modification, goes to the toilet every night before going to bed, or drink less fluid at night, white fizzy drink, then give them some reward. Okay, but it is important to tell the parent that do not give reward based on things that a child cannot control, like a dry night. Okay, because it's beyond the child control to remain dry at night, but the behavior he can control. So if he is, successfully following behavioral modification, then give him some reward, okay, to encourage the positive behavior. So we will follow all this and we'll wait and see for like 4 weeks or 6 weeks. And if still the child is not able to achieve bladder control, then we are going to refer this child to enuresis clinic for bedwetting alarm. Bedwetting alarm is basically the first line treatment. If the child is more than 7 years old and if he's going on, on a school trip, or he's going to spend the night over with a friend, so then for short-term control of enuresis, we can refer the child to enuresis clinic for desmopressin. Okay. So this is for short-term control. Okay, so I hope this video was helpful, and I will see you soon in the next video.